This video, and hopefully under 5 minutes, will explain why there is no reason to test, and indeed why you should not test for flu during the flu season. The rules are as such. Here's the key. If it's got a green circle around it, this is a patient that has the flu, and we test for the flu, and we know as an absolute truth that the patient actually has the flu. In that group, if there's a little red cross around it, that means the test is positive, and it's a true positive. If there is a yellow rectangle around it, that means that the test is negative and it's a false negative. And finally, patients that have a blue diamond around it are high-risk patients per CDC criteria. Those would be, for example, children with asthma, children under the age of 2, people over the age of 65, any significant comorbidities. This group is going to be a group of 50 patients that we are sampling throughout the flu season. Let's begin. Let's assume that this June, July, August, and maybe even the beginning of September. Note that there's absolutely no flu anywhere amongst our patient sample, and therefore no real concern. So this is the only epidemiological term I will really use for right now. Please note that assume that for every 10 persons that have the flu that you test, 5 of those will be positive and 5 of those will be negative. In other words, the false negative rate is 50%. All right, so if there's no flu, who cares, right? No harm, no foul, no worries about it. Let's say it's the end of September, and in this case we actually have 2 patients that have the flu out of our sample size. We test both of them because we're suspicious for them. And of those that we test, 1 comes back positive and 1 comes back negative. So a particular note, please note that none of our high-risk patients have the flu, and therefore it's irrelevant whether we test them or not. These folks over here, generally if they're not high risk, in fact by definition if they're not high risk, we don't have to treat them whether they have the flu or not. All right, now we're getting into October, and a greater percentage of our patients have the flu. So they come on in. We test 1, 2, 3, 4, 5, right? And they all are positives, and they're true positives. And then we test another 5 over here, and they are all negative. Even though they actually truly do have the flu, they're negatives. Therefore, they're false negatives. Again, of particular note, let's look at our high-risk patients, because those are the ones we're really concerned about. Note that in the false negatives, there are absolutely no high-risk patients. Now, over here, here's the key part. See this person? That person is high-risk. Because they're high-risk, by CDC criteria, they need to be treated. And because they have the flu and the test came back positive, they were treated. So congratulations. The flu test came back positive on the 70-year-old grandfather who has COPD and diabetes, and because it was positive, he was treated with Tamiflu, which is appropriate. Now we're farther into flu season. Please note that we again have randomly distributed our 6 high-risk patients throughout our population. So now the flu's really starting to take off. I have a random sampling of our population out of all 50. At this point in time, we now have 20 of them that actually have the flu. So we're suspicious for the fact they have the flu, and indeed it is an absolute truth that they do have the flu. So again, we test all of them, and test all of them. And in this case, of the 10 we test over here, they're all positive. So they come back as true positives. And over here, even though they actually do have the flu, they come back as a negative, which is a false negative. So, again, big point. Look over here. This person is high risk, and they tested positive for the flu. But because they tested positive, we treat them, right, with Tamiflu. And that is what the CDC recommends we do. Here's the concern. See this person over here? Now, we know that they actually have the flu because we know they have the flu. We assume that it's an absolute truth. We test them, however, and the test is negative. So now this person, this high-risk person, has just sort of slipped through the cracks, and they're not going to get treated. So let's say this high-risk person comes in, we test them, it's negative, but indeed they actually did have the flu. So let's assume this is, I don't know, an 18-month-old female with a history of bronchopulmonary dysplasia who spent a little bit of time in the NICU and is treated with, I don't know, bronchodilators because of a history of questionable asthma. So while you've taken care of the old dude, right, you've now sent home the 18-month-old female that actually is at huge risk, who is positive for the flu because you actually trusted the flu test and it gave you a false negative. Let's see what happens next as the percentage of patients that have the flu in our patient population increase even further. All right, now we're hitting flu season, and let's say it's the middle of January. It's starting to take off like a bat out of hell. All these patients have the flu. They come in with the flu. We test them for the flu. And as per the usual, what happens? We test all of them for the flu. Half of them are true positives, and half of them are false negatives. So we got all these true positive folks over here, positive, 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 more positive, 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 positive. And you can tell where this is going, negative. I'll just stop saying it. So again, here is the major concern. So we sort of lucked out with these people and these people. High risk. Over the age of 65, Native Americans, morbid obesity, diabetes, asthma, under the age of 5, certainly under the age of 2. Yeah, we're okay with this, right? Because they have the flu, they got tested, they were positive, so they got treated appropriately, which is almost always Tamiflu. So even though they're high risk, they're treated appropriately, so their risk decreases significantly. The big concern is, see is how, look, we now got 2 people over here, and here, actually we got 3, and here, right? So notice that as the greater percentage of our patients with the flu increases, the greater the risk that we're going to miss someone that is high risk. Because while we started off early with really not missing anyone, and then we maybe missed 1, now we're missing 3 people. So let's say that one of them is a 10-month-old female who again spent some time in the NICU. Let's say another one is an 88-year-old male with COPD and diabetes. And then let's say the other is a 45-year-old male who is morbidly obese. These are all people at extremely high risk. And we know bad things can significantly happen to them, which is why the CDC recommends that we treat all of these people. But because we've relied on our test, let's test over here, and these are all negative, we know they're false negatives, which means that all these 3 people, all 3 of them, are not going to be treated, which means there's a high likelihood of something bad happening to them. So I could continue going down this pathway if you like, but you generally get the idea. Right? As the percentage of patients in our population that actually has the flu increases significantly, our test becomes more and more unreliable. So the take home over this, and hopefully it'll be under 10 minutes because I lied about being under 5, is that just remember, because the sensitivity for the flu test is actually relatively low, about 50%. Some people say higher, but the data actually shows it's closer to 60 to 70. Some say as low as 50. That in the middle of flu season, as the percentage of our patients that have the flu increases, when you continue to rely on the flu test, the rapid flu test, your odds of sending somebody home who's at high risk, not treating them, not sending them home without Tamiflu, some 65-year-old person with COPD, a small child with diabetes, somebody morbidly obese, somebody that's high risk by any criteria whatsoever, If you rely on your flu test and it's negative, you have a significantly high risk of sending that person home without being treated, and they have a significantly high risk of coming back sick. These are the patients that end up in the ICU. These are patients that end up getting admitted to the hospital. So the whole take-home point about this is, in the middle of flu season, right, just because a test is negative does not mean you should pay any attention to it. I would argue that if a test is negative, and the patient clinically has the flu, assume they have the flu. If a test makes no difference in your clinical practice or decision making, there's no reason to order it. Given the high false negative rate of the flu test during flu season, there's no reason to test. If you clinically think they have it, simply treat them, especially if they're high-risk patients.